I think we'll probably have a few more people joining, but I think it's okay to go ahead and get started if you're ready.
Great, yeah, absolutely. So first of all, welcome everyone. Thank you all so much for taking time on a Friday afternoon for those of us on the East Coast, midday Friday for those of us that are not, or on the West Coast. I can't tell you how much we appreciate you all taking time out of your very busy lives and your very busy schedule to spend an hour with us. We are really, really excited about this opportunity to spend some time with you, talking to you about what we've been up to the last couple of years. The main intent of this entire discussion is to get feedback from you all so we can really hear what you guys think. So my name is Deb Stein. I am a trauma surgeon and surgical intensivist at the University of Maryland, and I have the incredible privilege as serving as co-PI with Anna Newcomb, Dr. Newcomb, on this project. And I'm really excited to introduce our other partners as well, and tell you a little bit about what we've been up to. And then again, the whole point of this is to get your feedback on what we've been up to. So let me start by acknowledging our funding institution for this project. That is the Patient-Centered Outcomes Research Institute, PCORI. This project was funded by a Eugene Washington Engagement Award back in 2019, 20, I think. And we were really gratified to, and I don't know if any of our PCORI partners are on the call. I hope they are. I apologize, I can't see everybody. But they've just been wonderful partners in this. And for those of you who are not familiar with PCORI, it is an organization that is entirely dedicated to assuring that the patient's voice is prominent in all research efforts. And it is really, I will argue, revolutionized the way research is conducted in the United States. I love your dog, Brian. I want to see more. I'm a dog person myself, so thank you. And so I am just really, really gratified to have you all here to talk to us today. So thank you, and thank you to PCORI. Hopefully folks are here. What we'll do today is I'll go over a little bit of what the Injury Research Engagement Project has been about, what we've accomplished to date and what we hope to accomplish, and then Dr. Newcomb will take over, talk a little about the first stage of this project. Then Dr. Applebaum will take over and talk about kind of the second stage of this project. And then Dr. Price will talk to us a little bit about the Injury Research Engagement Panel that will be the hopefully the sustainable and legacy project that comes out of this that will help inform research efforts going forward with respect to injury research. So next slide, please. So again, my name is Deb Stein. I am the co-PI on this project, and pleased to give you the project overview. If for some reason I say something stupid or you don't understand or you have a question, please feel free to speak up and interrupt. Happy to do that. This doesn't need to be us talking at you all. We want it to be interactive, but we obviously will have time at the end for questions and discussion. So if you would like to hold your questions till that time, that's obviously perfectly fine. For those of you who are not aware, and I think probably by the nature of being here, you probably are aware of the issue of injury as a major public health concern in the United States and worldwide. Injury is the leading cause of death for all persons ages 1 to 44. And a major cause of long-term disability. Injury is actually the third leading cause of death for all individuals in the United States, second only to cardiovascular disease and cancer. So huge public health problem. We know that research helps us improve our care of the injured patient, but the most effective strategies to improve trauma care require a partnership between researchers and the patient family. And despite the fact that we as the trauma research community, and I'll put myself in that, and I'll put that hat on for right now, albeit I'm also a clinician and I'm also a stakeholder by nature. We all know somebody who unfortunately has been the victim of injury. But despite having very long-standing relationships with Trauma Survivors Network and a variety of different organizations, we really haven't systematically engaged patients or caregivers in conducting our trauma research, conceptualizing, conducting trauma research. So that led us to kind of engage with PCORI and with the Engagement Award to develop the Injury Research Engagement Project that we're talking about today. We proposed an integrated partnership with the trauma's most vulnerable populations will inform our the project team's understanding of participants' attitudes regarding participation in trauma research. So first, we wanted to get a lay of the land. What are the issues? What are the barriers? What are the understandings? What are the misunderstandings? And then collecting getting feedback from our community at large, our patients, stakeholders, caregivers, about what is meaningful to the injured patient population with respect to what questions we should be asking, and how can we make sure those questions that we're asking are meaningful, respectful, and highly relevant to the injured patient. So the three objectives for this program were to establish a stakeholder injury research engagement panel that Dr. Price will talk about at the end, to partner in patient-centered outcome research and what we call comparative effectiveness research from conception all the way through to dissemination. And that's really the key, is that involving people who are ultimately going to be affected by the work from the very beginning all the way through to how do we actually implement this at our hospitals and in our patient care areas. We also wanted to develop emergency setting informed consent strategies and methods of follow-up, something that we know is difficult for our patients and their caregivers, and how can we better engage to get better follow-up, because if we don't have long-term follow-up, then we can't do anything that will actually meaningfully impact people's lives. And then lastly, to conduct this reciprocal education. And this is very much a back and forth. That's what we're here to do today. Largely, in addition to the lot of reciprocal education that we've done so far. Next slide. So this is just a little bit about our IREP network. The IREP works through the Coalition for National Trauma Research Network. And so those are our partners. Dr. Price is the executive director. Several other people who are on this call that you will see are all part of the center team. And then myself, Dr. Newcomb, Dr. Applebaum, we all are part of work within institutions that are part of organizations that are part of this network. And you can see here kind of the swath across the United States of our co-investigators on this project for this particular engagement project that we're talking about today. The activities that we have been engaged in and that we're going to talk about today, number one was the development of focus groups and the interview guides to conduct those focus groups to really get really granular details about topics of concern, and conduct virtual focus groups and Delphi surveys, which we have completed and Dr. Newcomb will talk about. To identify patients and caregivers' preferred methods for engagement in these types of research activities, including garnering some information around informed consent approaches and collection of long-term outcomes. Again, to formalize and establish a long-term sustainable process to over time be able to consistently and repeatedly engage patients and caregivers in injury research with the development of an injury research engagement panel. To provide ongoing education to share strategies with researchers that will increase research engagement. So this is a lot about us taking what we have heard from our patient and caregiver stakeholders and going back to the research community and saying, this is how you really need to do this well. And provide that ongoing education, and then assure ongoing national availability and engagement of the IREP panel and trauma research for use over time. So this again can be sustainable and long lasting. This is our stakeholders and collaborators. I don't know if I see our patient stakeholders, our patient partners on this call. I don't know if Alex was able to join us, but she's a good friend of mine, a survivor, but also has been just an amazing collaborator in this entire effort and helped us to conceptualize this from ground up. So you see here some of the individuals where people come from that we're working with on this, but very much including the American Trauma Society, the Trauma Survivors Network, and HAVI, the Health Alliance for Violence Intervention, have been just amazing partners in helping us to engage the community broadly. So I believe that I'm going to turn this over to Dr. Newcomb, if I'm not mistaken. And very much look forward to your comments and questions. So thank you all.
Thank you, Deb. Dr. Stein, we're going to go to the doctor route today, it sounds like. So
sorry, I don't even know where that came from. I don't think I've ever called you Dr. Newcomb in my life, so I apologize. Please call me Deb.
I'm delighted to be here, and I think I've met a lot of the folks here on the call because they were part of, or you were part of these focus groups that you're going to hear again about and what we learned from the folks. And Deb has already helped us understand why we got these focus groups together. We really wanted to get an idea of what was important to the patient and their family members, and what would be really relevant, what kind of research questions are really relevant. But we also knew that when we were going to have these conversations with you folks, and we also met with researchers, that we were only going to get a snippet or an idea of the various kinds of things that are important. We wouldn't necessarily get the whole picture of how important they were, just like what are the range of things. So we convened these focus groups of both patients and researchers and caregivers to talk about how they felt about these various topics. We ended up having 11 different conversations, and we asked our patients, our researchers, family members, would you rather be in a group of just patients and family, or would you rather be, if you're a researcher, would you rather be with just researchers, or do you want to be in a mixed group? Most people said, oh, I want to meet with everybody. And so we had a lot of mixed groups with survivors and researchers. Sometimes it worked out there was only survivors, but we ended up, as you can see, with a whole bunch of different times that people could meet so that we could try to capture a whole bunch of different kind of folks. Next slide. We ended up getting these 23 folks together over time. Yeah, 23. And they range, a huge range of age, 20 to 60, which kind of is fairly representative. But there's one group we didn't get, and I'll talk about that in a second. Mostly motor vehicle crash, bike crashes, domestic and other violence, pedestrians, falls from trees, orthopedic, internal, all these different ways of being injured and different mechanisms. The one group that we struggled to get that I noticed, and I had conversations with people that just didn't quite want to meet with us, which is the elderly falls from standing, or folks over 60 who fell. And I know that that's a big population. We just didn't end up getting them. Most folks were a few years out of their injury, somewhere between 4 and 25 years. And with regards to the researchers, next slide, we ended up having a range of researchers who wanted to meet with us and tell us their perspective, the early, the mid, the late career researchers. We had physicians who were clinical only. We had a lot of physicians who were clinical and bench scientists or research scientists, clinical research scientists. And then we did have our PhD and RN research managers and coordinators. So we got, I feel like, a nice range. So we interviewed them, transcribed the interviews, and found out a variety of things from the survivors. And we have actually already talked about this in one of these meetings about a year ago, so we're not going to belabor the information. But this is all pretty much a setup for when Dr. Applebaum talks about the survey that we did. What we are trying to do in these interviews is just find out what kinds of things we should ask people so that we get an idea of what is a more generalized truth than the 23 folks that we ended up talking to. So I'm going to go through each of these themes very briefly. Next slide. The survivors were really, we asked, why do you want to be here? And the reason we asked was because it's a little bit relevant to why would anyone want to participate in research. And the survivors really wanted, one thing was they really trusted the people who asked them. And that's why they decided to show up. But there's a lot of reason why some of the folks are here today, because they knew somebody who was who cared about this topic. They were curious about the other side. If they were researchers, they really wanted to hear from the patients. And the people were really curious about what the researchers were thinking. And they want to make a difference and really give back. The researchers felt like, same thing. They trusted the people who asked them to show up. They wanted to learn a little bit more about best practices, and they did. And they were very passionate about the topic. They, when we asked them what would make them participate, so that's very related to that, what would make you come today versus what would make you participate in any research project, they wanted to have this researcher, the survivors wanted to have the study presented to them in a way that they really understood in lay terms. They felt that it was important that they trusted the person who would approach them. And they really wanted to know, what are you going to do with my data? And how important is it for someone else? And let me see exactly where you're going to take the blood and how you're going to manage the blood. They wanted to be able to trust what was happening with the gift that they were giving. Researchers sensed that the best practices were similar. Speak in regular people language. Be clear about what they wanted to get. And also, don't just fake it. Know what you're talking about. And one thing that the researchers were really aware of is that if the clinical team is not well-versed in this particular research project, they could, unbeknownst to them, sabotage, maybe they never said that word, they could make it harder for the research team to really enroll folks, because if they're not really supportive of it, they may in some ways discourage their own patients from participating. One of the biggest themes, and Rachel will talk a little bit more about this, was trust. And so it seemed that in order to say yes to a project, to giving blood, giving survey data, you got to really trust the person who's asking you. And it was related not just to how their experience in the hospital at that point, but a lot of their own personal communities' experience with the medical system, their families' experience with the medical system. So if you are approaching a patient and they're like, nah, I don't think so, it could also be not about you. It could be about the whole community's experience with the medical system. Next slide. And when we asked about what would make you keep participating, keep coming back, the participants felt like it needed to be convenient, it needed to be not too expensive to them, we wanted it to be not too intrusive. One of the things that was interesting that I hadn't thought of that much was several people talked about how the environment that they returned to needed to be clean and staff needed to be friendly and they needed to be appreciated for giving this gift of their time and their information. They really wanted to know the value of what they were given, what was going to come of this information. Also, concrete things, transportation, parking, lunch, childcare, those things really mattered. And then in order to retain patients from disadvantaged groups, it was as if it was those things and a little bit more. We need to really recognize that sometimes the reason that they're not able to participate is not because they don't want to give us their information. It's just that they have a lot of competing responsibilities. And if we don't make it easier for those folks to participate, we're not going to get their information. For instance, again, the parking, the childcare, time off from a job. And oftentimes we found that folks from disadvantaged groups were vitally aware of how how we treated them with respect or not made a difference to whether they were going to consider. Next slide. We asked them what they thought a meaningful outcome for research would be, and pretty much it was quality of life. They wanted to feel better. They wanted to manage their pain. They wanted to be able to have a life again. They didn't necessarily say, I want the same life I had before. They just wanted some quality of life. And that they recognized that what's important to them was very individualized, might be different for what's important to somebody else. When Deb got in one of our meetings, she said, I want to know what you think of the word research. And after she asked that question of that one group, we continued to ask that. And we recognized that particular term to patients often meant being a guinea pig, which in my mind meant you're taking something from me and I'm not getting anything for it. Researchers recognized that, and many patients and survivors recognized that research was a way of finding a better way to do what we've been doing all along. The takeaway points were that it was the human connection that we make with folks and we're enrolling them and retaining them is really important. We needed to really genuinely be respectful, treating them with dignity. And interestingly, after each of the conversations between researchers and survivors, there was great appreciation for each other's role in this. The researchers were so grateful for the patients to show up. The former patients to show up, and the former patients really wanted to be able to have a little extra time at the end to remind the clinicians how much they appreciated the work that they're doing and the research that they're doing. Thank you, and it's on to you, Dr. Applebaum.
Wonderful. Thank you so much, Dr. Newcomb. As she had summarized, that was phase 1 of our IREP study. And really, as she mentioned, common themes evolved over different phases of research and different types of research and how we approach them. So our next step in phase 2, we were hoping to take those common themes and apply them to different research settings and see how patients, caregivers, and researchers respond. We were trying to develop consensus on these topics topics of how we really should be performing these different research activities. So we distributed vignette-based surveys, so basically a little story about a patient in a different research scenario, and we distributed these to key stakeholders, the patients, caregivers, researchers, to develop their preferences and values regarding those different activities. So one of the surveys, as mentioned, was given to the patients and caregivers, a second given to the trauma research community, and we were hoping to get a large number of individuals to respond to help us gain consensus. And we had used a Likert scale, so a scale of 1 to 5, to basically tell us how important these concepts are. 1 being not very important at all, and 5 being extremely beneficial. And we then wanted to compare the results for our researchers and our patient caregivers. We had a convenience sample for our sampling, meaning whoever was able to respond to our survey. We recruited through our surgical and trauma organizations, which we showed a list of earlier on in the presentation. We also recruited through our Trauma Survivors Network, Trauma Clinic. We had QR codes on little cards and posters. And as mentioned, it was vignette-based, which I'll show you as we move forward. Next slide. So our survey results, we had a total of 60 patients and caregivers that responded, 114 researchers, and the completion rates were 68% and 69% respectively. Our patients and caregiver characteristics had an average age of greater than 45, majority were female, and most of them were greater than 3 years out from their traumatic injuries, 68.6%. Our researcher characteristics had an average age greater than 35 years, and again, we're majority female. Next slide. So as we go through, I'm going to show you the different scenarios and vignettes that we proposed, as well as the different questions that were associated with those. I know the tables are a little busy, but I'll verbally explain what the key points are and what's important. So this first scenario we looked at were study outcomes. As Dr. Newcomb mentioned, we wanted to know what would make an individual feel that a study was beneficial to them. The patients and caregiver preferences were significantly different from the researchers. When identifying study outcomes as effective, they saw outcomes as beneficial if they helped themselves or others. They really had sort of an altruistic thought process of really just wanting to help someone, whether it was themselves or other patients in the future. Next slide. Vignette 2 is looking at the way we recruit for these different studies, whether we, hand them a piece of paper for a survey to complete, or whether it's given electronically. And the patients and caregivers were really open to all of these recruitment approaches, and approaches with written information possibly being the most significant, meaning handing them something that they could maybe look at later. Next slide, please. Vignette 3 looks at our researcher characteristics. So this is similar to what Dr. Newcomb was mentioning of, how the researchers interacting with the patients and caregivers. Are they hurried? Are they expressing compassion when they're talking with me? Do they know a lot about this study? The researchers thought it would be most important that the research staff was unhurried. They sat down, they took time to talk about the study, to introduce the clinical care team even, and also to be racially or ethnically similar to the patient. And the patients and caregivers in this survey, we found that that was less important factors to them. Next slide. The next vignette looks at survey format. So how we're giving the survey, similar to vignette number 2 of the approach. And in this one, we found that there were no significant changes for this particular study format of whether the survey was given via an automated system like a QR code, whether it was over the phone, via paper, or with an iPad. No significant difference between the individuals. Vignette 5. Vignette 5 is looking at a blood study. So this is one where a patient's in the hospital and they get enrolled in a study and they're having their blood drawn. And in this case, it was blood drawn at 3 different times during their stay. And patients and caregivers thought it was more important that there was almost no risk to their health for participating. The process of what would happen to the blood was also explained in detail. That was similar to our phase 1. And the researchers thought it would be more important to the patients that the study is not likely beneficial to them in any way, that the patients had already had their blood required or drawn throughout the day, that would impact whether they would want to participate. And the sight of the blood may make them queasy as well, or uneasy, might be another reason that they would not want to participate. Next slide. Vignette 6 is an intervention drug study. So this is one where we would be testing a certain medication, or they would receive that medication, and then wanting to know how important certain aspects of that study would be, and whether they would want to participate in that. So the researchers, again, thought it would be important that the research staff was unhurried. They took the time to discuss the study. They also thought that having the same race and ethnicity as the patient might be important in terms of building that rapport and building trust. They also thought that it would be impactful that the patient's pain, if it was not well managed, that could make them less likely to participate. And that the patients had maybe unpleasant experiences while in the hospital, maybe a long wait in the emergency department or interactions once they were admitted. That could be impactful as well. They also felt that the impact of the study did not benefit the patient in any way. If that was the case, that might be something that may stop them as well, or impact whether they wanted to participate. Vignette 7 looked at required follow-up. So this is a study that we wanted to know, well, if you had to come back to the clinic and follow up, at 2 weeks and at 6 months, how would this affect the impact? So again, comparing patient and caregiver results to the researchers' thoughts. The researchers here thought it would be important to have patient follow-up on the same day as their other post-op visits. I know for some of our patients online who have followed up after trauma, getting that coordinated to maybe do it all at one time can be significant, because it can be hard to get back and forth. They also thought transportation, if that was given, or meals were arranged during the clinic visit, that would be something important to the patients. That the patients were paid. The study did not benefit the patient in any way. That could maybe be a negative reason for why they would not want to participate. That the clinic was clean, that would be an incentive. And also parking costs, maybe that would be included, making it convenient for the patients and caregivers to participate. Those were all found to be important from the researcher perspective. Vignette 8 is looking at a legally authorized representative. So that's more so a situation where the patient themselves could not participate, but rather one of their loved ones was stepping in to help give permission to allow them to participate in a research study. So again, we wanted to know, are there certain components about the research staff, the experience, that would make them more or less likely to participate? In this scenario, the researchers thought it would be important that the research staff was, again, unhurried, that the care team maybe made the introduction to help build rapport and build that trust. The researcher had experience with trauma. The researcher was the same race or ethnicity of the patient. Maybe, again, prior unpleasant experiences may decrease their likelihood to participate. Researchers did not give a break, or the patients felt overwhelmed, given that they had a lot of information being presented to them at once. And then the possibility too of not participating, that no family support was present to help make the decision. The patients and caregivers on the other side thought it was important that the patient understand the possible risk of any poor outcomes if the caregiver agreed to proceed with the research itself. So understanding the risks and benefits was a big factor for the patients and caregivers. Next slide, please. Oh, very good. Vignette 9 is looking at EFEC, exception for informed consent. So similar to the fact that you may have a representative present as part of the study, exception from informed consent is research that occurs in an emergency. So this is when the patient or even their loved ones may not be present to provide consent yet. And what happens is the research team can enroll the individual in the study, and then later on come talk to the patient and family member to talk more about the study and ultimately get their permission to participate. So knowing that their loved one may have already received a treatment as part of the study. The researchers in this scenario thought it would be important that if there was any unpleasant interactions in the hospital or impacts on the patient caregiver, that could affect their want to participate or continue participation. The caregiver also, if they had not received a break or were very overwhelmed with what clinically was going on for the patient, that too might be a reason that they would not want to participate. The patients and caregivers, on the other side, thought that it was important that the patient understand any possible risk of poor outcomes if the caregiver was going to have them proceed. The researcher also wanted to be able to understand any harm that could occur as part of the study, and also if improved outcomes could be present as well for this patient as part of the study. The patient and caregiver also had a preference in this scenario towards a printed flyer. So again, going back to that prior vignette of having something tangible to be able to have to refer back to was important to the patient and family members. Next slide. With all that being said, we did notice some differences from our phase 1 outcomes, and this was a little surprising to us. We noticed that the motivations to participate, we thought the researchers picked up more on in phase 2 in terms of that being important to patients and caregivers, but we didn't necessarily see the patients and caregivers having that same input. Additionally, from consent practices in terms of the researcher being unhurried or the researcher's approach, their characteristics, race, and ethnicity. Again, the researchers thought would be more important, but the patients and caregivers did not. This made us wonder if a change in the way we were doing this phase of the study with the survey, if it led to these different results we were seeing. It also brought up a concern that maybe our sample wasn't as diverse, or we needed a larger number of individuals to be able to have more insight into what was going on. So this made us think that our qualitative in-depth interviews that Dr. Newcomb described in phase 1 may have actually had a little more of a diverse population because we intentionally sought out a diverse population. And we also had in-depth conversations that may have given us better insight overall than maybe our survey structure did ultimately. Next slide. Next, I'd like to hand it over to Michelle Price to talk about where we go from here in regards to the development of our research engagement panel and next steps with our project.
Thank you very much. And I'd like to echo our gratitude for all of you making time to join us today. We appreciate you being here. So I'm going to talk about what is coming next in this project. So this project is actually officially wrapping up at the end of November. And so we've got a few things that we're doing between now and then, but we also have a long-term plan. And all of this really centers around our group of researchers wanting to do as much partner with patients as much as possible throughout the entire life cycle, if you will, of conducting research. So like you heard, so having patient partners involved in deciding what to study and how to study it, and being patient researchers on projects, on grant applications, which is a requirement for organizations like the Patient-Centered Outcomes Research Institute. There we go. Okay. Next slide, please. So the next thing we're going to do is to actually convene a panel of patients, trauma survivors, and caregivers to advise trauma researchers on projects that are currently underway or new projects that are being conceptualized and grants that are being written. So what we're going to do is partnering with the American Trauma Society's Trauma Survivor Network and the Health Alliance for Violence Intervention, which were both funded sub-awardees on this project. We are going to create a panel of patients and family members and caregivers that is ethnically and geographically diverse, that is comprised of survivors of both unintentional injury and violent injury, folks who are interested in partnering with trauma researchers at one or several stages of the research process, and who are available to meet with researchers during quarterly web-based meetings or as needed to discuss new proposals or ongoing projects. Next slide. So here's what we think this panel will be doing. It's to be determined to some extent by the people who volunteer to be on this panel, and it's a collaborative process of deciding how we're going to conduct business. So we will establish a process for how the panel will collaborate with researchers in deciding, and these are the phases of research that PCORI recognizes: deciding what to study, how to study, planning the study, finding participants, and then sharing those research results in a patient-friendly way. The stakeholders will provide input on the inclusion of meaningful outcomes. What would the patient like to learn? Going back to what Anna was talking about earlier. They will assist researchers in developing study materials and study processes that are patient-centric, patient-friendly. They will also participate in studies as patient partners, so named co-investigators on studies with compensation for that participation. They will help us as a community of researchers improve both the quality and the quantity of patient engagement in trauma and burn research. And then finally, they will serve as a standing engagement panel for Olive Center's ongoing projects. Next slide. So here's our long-term vision, that we create a sustainable panel that meets regularly beyond this project. So that's something that we recognize that we need to fund and sustain moving forward. Center will fund the panelists' participation in the meetings by providing an honorarium. Investigators in Center's member organizations can access this panel as needed to talk to them about an idea for a study, or maybe they're wrapping up a study and they're developing patient communications and they'd like some input on whether or not what they're writing makes sense to a non-clinician or non-researcher. The panel will regularly engage in new center funding applications. So as we're writing applications, we will bring them on board to participate in planning meetings, to write a letter of support, to have a role on the project as appropriate for the different funding mechanisms. And then we will, what we think this will result in is that investigators will begin to build the IREP into their research activities and funding. So in other words, they would plan to have a meeting with the panel as a representative group of stakeholders at specific points, and they would plan to pay the honoraria for those studies, those meetings that are specific to their studies. Now, the meetings themselves will all take place over Zoom. And they will take place more than likely in the evenings. The goal is to make these meetings as convenient as possible for patients who have competing responsibilities and may not be available during the workday. Next slide. So starting with this meeting, well, we've done a little bit of recruitment before this meeting, but this is really our big announcement and rollout. We're going to start recruiting panel members. We are reaching out to our IREP partners, and we have been doing that, and center member organizations like the American Burn Association. I was just meeting with them earlier this week. We are inviting patient collaborators who have already worked with us on other projects or have presented at conferences that we've organized to consider serving on the panel. We are going to invite all of the participants of our focus groups to consider joining the panel. And then if any of you today are interested in joining, then we're asking you to please email research@nattrauma.org or any of the other connections that you have with us. They'll get the message to me, and then we will provide more information about these panels. Next slide. So as I said, the formal project is wrapping up in November. So we have a little bit of a tight timeline because we'd like to have time to have 2 Injury Research Engagement Panel meetings between now and the end of the formal project period. So we have planned for the first engagement panel meeting to be in September, on September 27th, which I realize is a quick turnaround. And that's why we've already been doing some outreach to potential panelists and having them save those dates. And then we'll meet again 1 month later. And then we have a final stakeholder meeting scheduled for this group, well, for this project, I should say, November 15th. And then our plan is moving forward, that we will have quarterly Injury Research Engagement Panel meetings starting in 2024. I have been asked to put the email address into the chat for folks who are interested in signing up. So I will do that right now. Okay, next slide. So if you'd like to hear more about our project, this is a shameless plug for, we have a poster that's being presented next week at the American Association for the Surgery of Trauma. Some of you may be planning to attend that meeting, and Dr. Applebaum will be presenting our project as a poster. Dr. Applebaum, do you by chance know when you're presenting, on which day and what time? Okay, you're on mute, but while you're looking that up, we can go to the next slide, which is basically just where we pause for your feedback and questions.
I think the posters are Thursday around noon, sometime between 12 and 2.
Yes. Thank you, Anna. Yes, it's on the 21st of September, 12:45 to 1:45, and I believe I'm the first poster in that group. So 12:45 would be great to see everyone.
I'll put that in the chat.
Michelle, if you're interested, we could show the patient's video that we created to get people interested in doing the survey.
That would be great. So while she's pulling that up, I'll give you a little background. We decided when we were switching from focus groups to doing surveys that it might be helpful to record a patient talking about why he thinks trauma survivors should get involved in research. And so it ended up serving two roles. One, it helped us recruit patients to take the survey, but also it became our first patient-centered piece of communication coming out of this study, geared toward patients, encouraging them to take part in research. And it's very short, so whenever you're ready, Pam.
I was leaving a barbecue and I was shot by a stray bullet. I was hitting the back with a Desert Eagle, which is a 50 caliber handgun. The round went into my back, it hit my aorta, and then there was a bunch of complications to follow up. Up to date, I've had 22 surgeries. One of the main ones being reconstructive stomach surgery because of the fistula. So they had to remove my large intestines. They had to remove my appendix. They removed my gallbladder. I became a double amputee, but I do have prosthetics. I'm still active. All of us as a whole, we have to take control of our narrative. And we have to speak on what's affecting us and make sure that that's getting out. And also it's going to help research for people in the future that may go through. So use this survey for you to be your own voice. You just got to keep pushing through. That's the biggest part, is just keep fighting. Just keep fighting. Things are going to be different. It's not going to be the same. It's not going to be easy. There's going to be days where you want to quit. I wanted to quit a lot, but I just couldn't. I couldn't quit. And I'm glad I didn't, because the impact that I have on lives now is greater than anything I could have done with legs. I hope everything goes well with you guys.
Thank you. I think we're having a little trouble with the audio, but this is something that will be available on our website. And we would love for other folks to consider using it for recruiting to their studies. We do have quite a bit of additional work to do between now and the end of the project in terms of developing other materials for patients based on what we've learned in the survey and in the in the focus groups. And we intend for those to be study agnostic, if you will, so that if we end up developing a piece on exception from informed consent or legally authorized representatives, that it will be available on our website, and any researchers can use those materials, make changes to them, put on their logos, and hopefully improve the way they're communicating with patients about trauma research. And the group would be happy to take any questions with the 15 minutes we have remaining.
Questions for us or thoughts? What can we do better? What did we do badly?
So I have I'm Jennifer Cathers. My daughter is actually the trauma survivor. And I know we spoke with our local trauma survivor network through Westchester. Are you looking for people who are under the age of 18? My daughter was only 15 when she was injured. She's 16 now, and has a bit of a voice about some of her experience along the way, which was similar to many.
It's a great question. And my initial response is absolutely, but I do think we just need to check. I don't know from a requirement perspective if we specified age, should we?
No, we didn't. I think it's a great question because pediatric trauma research is a whole other issue that we don't know a lot about in terms of the patient experience. So if you don't mind, would you please just email me with your information, and I'll follow up with you. I'll do a little checking and see if there are any considerations we need to be aware of. I appreciate you suggesting that she participate.
Yeah, absolutely. I mean, if not, as caregivers, we have no problem doing it as well.
That would be great too.
But she certainly,
we realize that we're asking a lot of your community to join us in this. And we're asking for time and energy and emotional energy, but we also so appreciate with you as people who obviously understand the importance of this. And so, yeah, we will take any volunteers that are interested. We would love to have wide participation. So thank you so much.
sounds good.
I wonder if we should give a little heads up of what we were thinking we might do during those 2 panel meetings. We have not formalized it, but we're thinking the first panel meeting, which is September 27th, we would do some education. We're not reinventing the wheel, but Corey has already written a lot of good materials on educating lay people on the research process. So we were going to do a bit of that in the beginning. And then the second meeting, we were kind of hoping, not to put you guys, Deb and Rachel, on the spot, but we know you have projects that you're working on. And we were hoping that you guys would be able to present very briefly what this project is and engage the panel in providing some feedback on how best to approach some of these questions that you guys have. And that would give us, and we would probably do that for about half of the time. And then the second half of the time during that meeting, we would think together with the researchers about what's the best use of not researchers, the survivors, what's the best use of our time in giving feedback, and how do we best present a study so that your hour and a half that you give to us is really well used. So that's what we're hoping to do. And it's totally fine if you don't make the first meeting, but you can make the second meeting, because we will do a real brief recap of what you should know. And it's also fine if you can only make the first one. We just would really like to get the sense that we are on to something by actually being interesting enough that folks would come and join us. So, and I know sometimes being interesting is not enough. It's like also your schedule, but we'd really like to have you join us, because that was sort of the point, is put together a list of people who would help actual researchers make decisions about how to do it.
And another point too, I'll say, is that because we were coming down to the last bit of this project, we actually had a time crunch on getting these meetings on the calendars. And so they ended up being late in the day, not in the evenings, but our plan moving forward in 2024 is to have these meetings scheduled way in advance in evenings where hopefully a lot of patients and family members can join us.
No, I would say I'm very excited about the panels, and especially the opportunity to maybe even present our work as an example to see. Dr. Stein and I are partnering on a study looking at EFIC, just as we were talking about exception for informed consent, to see if we can make those study materials better. It's a grant we just submitted, so fingers crossed. But I think it would be great to get your insight on what we have so far.
And just to say that grant came out of our fumbling that conversation meetings with you guys. So Catherine and I ran these focus group meetings. Rachel was there at most of them, and Deb was there oftentimes. And we did bring up this conversation about exception from informed consent. And we didn't really know how to have that conversation with you because it's really complicated. So what we discovered was maybe Corey can help us study what would make it feel accessible to regular people, not just confused researchers, but regular people. And that's what we are, or that Rachel has put together, that we're going to look to get funding. And that came straight out of this, the conversations that we had with you, which you may have looked at us like, what are you talking about? I don't understand that. Well, now we hope to get a better idea how to communicate that.
Wondering if there are other family members or trauma survivors in this meeting that have any just kind of general impressions about our approach. Any questions about, potential impact? Why would I want to spend my time on this? I can tell you might be wondering how much the compensation is, and it is $100 per meeting. And we think the meetings will be between 1 hour and 1.5 hours. And we'll be handling all those payments and all the particulars that go into setting that up. But any other, questions or thoughts and reactions?
As a survivor and a caregiver, more so a caregiver than a survivor, I want to thank you for listening to our voice and hearing the voice and trying to do better. Our incident was over 22 years ago, so lots changed in the medical field, thank goodness, since then. And thanks to a lot of people on this call who do programs in educating not only the doctors and the residents, but also all the staffs in all types of facilities to help educate everyone involved in how to communicate better with the families and the patients themselves. In our case, my daughter was so young, so she wouldn't have understood anyway what was going on. So it was more communicating with my husband and myself. But so I do want to thank you all, and it doesn't go unappreciated by the family members and the caregivers, because you are hearing our voices and you are trying to make it better, which we're all trying to do.
Well, thank you so much. It means a ton to all of us to hear you say that. So thank you. I hope that you can appreciate that this is very much a first step in this process for us, and hopefully for you all as well. And so to your point is, we have only scratched the very, very, very surface of this, and our ability to really educate around these issues of how to be more responsive and how to be more excuse the expression, patient-centered. It comes off as trite. I have hearing that over and over again, but it's really true. It's about putting the patient at the center of our conversation. So thank you on that. That really does mean a huge amount to us. But please understand, we are by no means done here, and so we really do value your feedback and your assistance going forward, so we can continue to improve and grow. We have a lot of work to do.
There's a question in the chat about whether surgeons are also invited to join, or is just patients?
The panel is intended to be patients and caregivers, but we want people, we want the opinions of people who don't necessarily have a vested interest in research for the research itself, but research that puts the patient in the center. But I think that we'd be interested in having any individual who has a perspective that would be unique and different and instructive to us, as the research community. Like, for example, like I said, we all, I don't think any of us have been untouched by injury in our lives. But the intent here is very much to make sure that we get that voice that we aren't otherwise getting. So if anybody who can bring that voice for us would be great. Yeah,
Can I say something?
please.
Okay, so my name is Patty Byers. I'm a trauma surgeon for 30-something years, and basically I've evolved with a surgical nutrition service where I basically take care of the patients that are the complicated patients, like the person you had on the video. And that really caught my attention because I have a very patient-centered team while I'm part of the trauma team, but while everyone else is running around doing all the disasters and the emergencies, my team, made up of a fellow nurse practitioner, pharmacist, residents, basically have a huge outpatient service where we actually follow people like him until they're well and do the reparative surgery that takes 12 hours or 11 hours at times, and are a resource for them. And so I can't tell you how moved I am that you're actually focusing and you would have that patient. Because I think that as trauma surgeons, what I see is, I always say you can save someone, but can you make them better? I mean, can you make them so that they're okay to live in their life again? And I think what you're doing is like amazing. So if there's any way that I can help or be involved, because this is exactly where I'm at. Okay, so what you're doing.
Well, and I think, Dr. Byer, I think that it sounds like you would bring a really unique perspective for us because, as you know, as a trauma surgeon, right, there aren't many people like you who are out there doing the back end work to get people back to wellness. And that concept of wellness is really motivating for me personally. I know for Anna, for Rachel, for Michelle, for all of us as well. And so yeah, please give us your contact information. I think at this point, we want to cast the widest net possible. So we make sure that we are really honing in on the issues of vital importance. And it sounds like you would have a great voice to bring to this. So thank you. Thank you for participating.
Oh, thank you for what you're doing. Thank you for that you're bringing this viewpoint. I think PCORI grants are fabulous. I actually tried to get one for intestinal failure, but somebody else was applying for one at my institution, so they wouldn't let me go forward. So congratulations on getting that. I knew that this grant was coming out for engagement. So congratulations. But if I can get in at the back end and help in any way, I mean, I'm in.
Do us a favor, please let us get us your contact information so we can reach back out and be in contact.
Okay.
Thank you so much.
All right, thanks. I will. right now.
All right, I want to be respectful of everybody's time. We've already taken an hour of your pre-weekend. Does anybody have any other thoughts, comments, feedback? Please feel free to reach out. Obviously, I'm sorry, did somebody? Yeah. Did I see somebody raise their hand? Oh yeah, please go ahead.
Hi, I'm David. I'm from the Gold Coast, Australia. I'm a TSN coordinator, but also a survivor. And one of the things, what you're doing is fabulous. I think any engagement and research, we need it to move forward. And one of the things that we've been noticing a lot is with the lived peer support that we get our trauma survivors and their families. It's been sort of almost overwhelming on how productive and useful it is. And we've been noticing a lot of questions and engagements from the survivors and their families towards the peers of the live peer supporters. Very interesting, because all of a sudden we're seeing, rather than questions being directed at a clinician, they're being directed directly at the peer supporter, and which is a very fine line, because the peer supporters are not clinicians. So it's a very fine line, but we do a lot of training now. So to keep that engagement moving forward, but also allow the peer supporters to go back to the team to be able to help unravel whatever those questions may be, if that makes sense. But just all this research and anything we can get out of it, which I'm sure will be an enormous value to all survivors and their families, and also the trauma facilities that allows us to move forward. So well done. I'd love to be a part of it. Sometimes it's going to be difficult. I missed the first 5 minutes of this webinar, unfortunately, and that's because I ignored my alarm at 5 o'clock this morning because we're a day ahead.
Well, we thank you for joining so early on a Saturday morning. And thank you. And you just sparked my interest in another potential new avenue to explore, which is how we engage our peer support, army of peer support individuals that we have, that we can, to help us engage that group of individuals that you all work with, who work so closely with our patients and provide so much vital information. So you just completely sparked my interest about an entirely new idea. So I'll be in touch.
Oh, absolutely. Up until recently, I co-hosted what we call the international support group now with Trauma Survivors Network, and the survivors that we get on, the information they provide just in our group support, and the hints and tips and what the information they want to know, and share on how they get that information. It's very valuable stuff. So I look forward to getting in touch, and I've got Michelle's email down there, so I'll send out an email to Michelle and we'll hopefully come together somehow.
Perfect. Thank you.
It's been awesome. Thank you.
Thank you. All right, 1 minute over. I hate going over, but thank you all so much. If anybody has other thoughts, comments, criticisms, whatever, we really want to hear from you all. We thank you so much for taking the time. Please feel free to reach out.
Can I have one of your personal emails? I'm sorry, I cannot send an email to that. My Outlook is blocking it because it's not a recognized person.
Dr. Byer, if you signed up for this webinar, I have your email and I can email you so you'll have us.
Perfect.
Great, thank you, ma'am.
Mhm.
But please feel free to reach out. Michelle, we can all be reached through the center website. Maybe Michelle, we can put that just in the chat. I don't know if you did or not. Just so people can go to that website, and that will absolutely reach us. So if there's other additional feedback that you would like to give to us, we would love to hear from you all. And so look forward to working with you all in the future on this. Like I said, this is just the very surface of what we're looking to do here. So we're very much looking forward to this being a long-term partnership. So thank you all. Michelle, Anna, Rachel, any final words, or any of our other collaborators who are on here?
It was great seeing so many of the people who joined us for the focus groups, and I'm so grateful for you guys, and also for those folks who completed those surveys. Really important. Thank you guys for being there, and we have sent out invites to many of you for the panel, and I'm excited to see you there.
All right. Thank you all so much. Have a wonderful weekend. Everybody, please stay safe. Thank you.
Bye-bye.
Bye.